Are we on? Yes, we're on. You can all hear me. Okay. Well, thank you all for coming. This is amazing. The Secret Service says this is the largest crowd ever to discuss the public option on a Friday afternoon in Washington, D.C. It's true. There's clearly a huge interest in what these governors are doing on the public option late on a Friday afternoon, and I guess that's a comment on the interest in the public option. It's a comment on the two of you, and it may say something, and I don't know how good it is about all of us, but we're all really interested in this. If you could all do me a favor, though, please just silence your devices, because we are streaming and welcome our webcast audience. Also, thank you for the time. I remember when I was a State Human Services Commissioner accompanying my governor to DC for these trips in a dilapidated, barely flying old New Jersey State Police helicopter. And so I know how hectic your schedules are on these trips. You know, you've both been in Congress, you know every inch of this town. But thank you for making the time to do this. We wanted to do this because what these two governors are doing is so important. The idea of a public option originally emerged in a significant way in the ACA debate. Obviously, major candidates are proposing it. Our polling, many of you follow our tracking poll, shows of the major ideas, it's the most popular idea. It's more popular than Medicare for all, and it even has significant Republican, not majority, but significant Republican support. So if I had to pick one idea which I think has staying power, even potentially, depending on what happens beyond 2020, it might be the public option. But it's still a heavy lift, and these two governors are actually doing it. And I have tremendous admiration for governors who step out front on difficult issues, and our issue, and challenges like this. So thank you for being here, and thank you for being here. Let's get started. We'll save a little time for audience questions. I am not Mike Wallace, so I don't even feel the need to start with a question. I thought I'd just start with an invitation for the two of you just to talk for a couple of minutes, so we have time for other stuff, about why you took this on and what you hope to accomplish in any order you want. Alphabetically, I guess we start with you. And if you want to wind up interviewing yourselves, I'm totally happy to be a potted plant. That would be fine. So, floor is yours.
Well, thank you. I'll just ask Jared. Jared, do you think we're the two most accomplished governors in the United States on this issue?
Well, you've had a little longer at it than us, but I think Washington and Colorado are very much in the forefront of healthcare reform, saving people money on healthcare. There's bits and pieces that you can learn from different states, but I think a lot of folks are watching Colorado and Washington.
Well, congratulations to both of us. We're the best. Thank you, Jared.
I was more diplomatic about it, Jay. I
want to answer your question now. Like, why did I get involved in this? Just one little small anecdote, because that's what life is made of. I got a new hip before Christmas, and I had the darnest experience because it was a wonderful experience. I was treated so well by the healthcare folks, who are just geniuses. And when I woke up in the recovery room, I was warm, I was comfortable, I was not in pain, and the first thing that went through my mind is, can I imagine if I didn't have insurance right now and couldn't get a hip and was a 60-year-old guy on a cane for the rest of his life? And I don't know why. I mean, I was literally just coming out of the anesthesia, but that's the recognition I had of how pivotal this work we're doing. And what we did in Obamacare has been a spectacular success. 800,000 people in my state, 35,000 people have had life-saving cancer treatment as a result of this. We've kept Medicare inflation rates below 2%, which have been an extraordinary success. And that's one of the things that doesn't get talked enough about, is the cost containment features of this and what we now hope to do in the public option. So it's been really successful. We reduced our uninsured rate from 14.5. It got down to just below 5. It's now crept up to 6.2. But that means there's another several tens of thousands of people who maybe not have access to the surgery I had before Christmas, which has gone wonderfully. So we're just highly motivated in this subject because it makes such a life-changing difference to people. And the version, if I can just briefly tell you how we came up, the structure we chose for the public option is one that essentially will put the scale and scope of the state of Washington imprimatur of state coverage behind this system, pick 160% reimbursement rate for providers of Medicare rates, so it's a healthier than Medicare and Medicaid, has some protections for rural hospitals. We use the private sector for the administration of it through private carriers. Not everyone will choose that. We chose it because it will avoid the massive initial investment that otherwise the state would have to make to set up the entire administrative network. So we thought it made sense to use the private sector as that administrative function. And the current status is we're going to go out for bids starting this fall. We now are in the dance of the medical profession with providers to see who's really going to be there when the bell rings. And that is unresolved at the moment. There are serious discussions going on. I would consider myself optimistic about the success of really getting healthy networks to make this thing work. So I'm excited about what we're doing. We're going first. There is risk in going first, but I was talking to a little group earlier. It's about the people in the medical profession who have taken risks to create new surgeries and new drugs. They've taken risks, and we have to take risks in this, or we're not going to advance to make sure everybody's got coverage. And this is one, I think, well worth taking, and we'll see whether it becomes a template for other communities.
And you both also heavily emphasize making healthcare more affordable and taking on the problem of people's costs, which is what I emphasized in your quotes that I chose up there, which I think is important because that's what drives consumers, the public, voters, worries about that governor polls.
Jay, does yours go live in 2022 or 21? When is it?
21. And,
so we're 1 year. We're 1 year behind. We're usually the same time. Colorado and Washington legalized cannabis the same year. We tied them. They're 1 year ahead of us on this public option. So ours would go live January of 22. We are doing a lot now as well. And by the way, the way we define public option very similar in both of our states. It's a similar market channel for the product, namely through the existing insurers with requirements that they carry it. In our state, we have 22 counties where there is only one insurer in the individual market, often the small group market. That is not a competitive landscape. We also, like a lot of states, have had escalating costs. One of my first actions as governor, we created an Office of Saving People Money on Healthcare. Our Lieutenant Governor, Diane Primavera, strong background in healthcare, is ahead of that. And we see the public option as part of a multi-pronged approach. So we're doing a lot of other things, and we're going to mostly talk about the public option today. But I also want to talk about the work we're doing to end surprise out-of-network billing. Our reinsurance program, I think we were the 9th or 10th state that it brought down rates in the individual market by an average statewide of 20%. But beyond those numbers, some of the highest priced areas in rural Colorado, it brought down rates by about 30% in the individual market. That's live now. So that's having tangible impact, saving people money, and also people who weren't able to have insurance before are able to afford it. A lot of those reforms the reinsurance is targeted for the individual market. In our state, that's about 7%. It's a smaller group in Washington state. Now, when we talk about the public option, we're talking about individual and then going up to small group. So it's a larger percentage, somewhere around 15% of the addressable market in our state, is we hope that these reforms are cost saving across the board. One other model that we piloted and are expanding, we call it the alliance model. It's kind of a purchasing alliance model. It's live in one county this year, Summit County. We hope you all come to ski in Breckenridge and visit Frisco and that area. That's the area, of course, workers in the community, one of the highest cost communities in our state. So this year we went live with the alliance model. What that is it negotiates, what's a sister nonprofit, negotiating with lives across different carriers and going in to the providers and negotiating with a larger group of lives, essentially, both from the individual market and the small group market, potentially large group too. We have some public employers that are in it, like Summit County as a county employer. So that's very successful. The headline that I keep at the top of my Twitter feed, @JaredPolis, shameless plug, is that the headline from the Summit County newspaper was premiums going down 41%. So that's our marquee county because it's reinsurance, which was 30, and alliance, which was 11. Now the alliance model we're expanding to nearby Eagle County, come ski in Vail and Beaver Creek, and then also in southwest Colorado, which is the Durango area near the New Mexico border. La Plata County and about 5 other more sparsely populated counties in the area. Those will be live in 21. And then we look forward to continuing to expand that. Now, the public option. So this is the issue where, again, 22 counties, no competition. How do we provide some downward pressure in rates, right? And so we sort of backed into it from an actuarial model where we want to save people about 11 to 19%. So this will be an additional 11 to 19% savings, reduction in the individual market, above and beyond the reinsurance and the alliance where we make it live. And we do that in 3 ways through this public option, which, just like Jay's, is offered through the insurance companies with, in some cases, a requirement that they carry it, depending on how the competition is and who has it there, but offered through the insurance companies. We do 3 things. One is we reduce the medical loss ratio. So again, we go to 15% instead of 20%. So it's essentially the same deal they have for large group, applying that to small group and individual market. 2, as you know, this whole area of pharmaceutical rebates has ballooned, especially since the Affordable Care Act, because it's a way around all the regs on medical loss ratio and everything else. So we are going to capture all of that, as, by the way, some providers do. Like I would emphasize, we have Kaiser Permanente in our state. They capture that today. But many don't. It's PBA, it's pharmaceutical benefit managers, it's insurers because it gets around medical loss ratio. And it's just ballooned. I mean, I was shocked to find these rebates are now something like 20% of pharmaceutical costs. I mean, this has just been, on our watch because it's not really regulated. So we're going to dollar for dollar recapture those rebates and use it to offset lower premiums. So that's the second source of lower premiums. And the third source is similar to what Jay mentioned, is the reimbursement rates for hospitals. We also are starting with a base of about 160%, as Jay would say, keeps them whole. I think in our state, the average cost was something like 130% of Medicare, so it keeps them whole. And then above that, we also have a formulaic, transparent formula for rewarding good behavior and efficiency, meaning hospitals that have a higher load of Medicaid and Medicare get a bump on their public option reimbursement. Rural providers get a bump. Ones that have lower margins get a bump. So there's a transparent formula that provides a bump above that basic level of reimbursement for those hospitals. So that's essentially how the public option works. Similar structure to Washington through the private providers with negotiated rates and downward pressure on rates, and then recapturing some of the money. And then when you back into it actuarially, it's about 11 to 20% savings.
Terrific. And you also have a drug reimportation plan, and you have
Yes.
a long-term care insurance plan. So the two of you have really taken on healthcare. Someone in this room wrote a column that said the action is in the states. The action is in the states. Well, let me start with a question, just a simple question. What's been the hardest thing, the biggest challenge about doing this so far? Some guesses, but we want to know from you.
The hardest thing is going first, right?
Yeah.
And I mean, going first in any endeavor has risks, and some risks that you might not even recognize at the moment. Look, we're in a risk because we have to get the provider community to be involved in these systems, and so we're out there now testing that hypothesis and judging some of the fine points to make sure we get those providers in it. So, but it is a risk well worth taking to get to those last tens of thousands of people and to have a mechanism to drive down costs both. And we think this is the best measure for doing it. Certainly, and this is important too, that at the same time that the current administration and the current majority in the U.S. Senate want to take away people's health care, which is what they want to do. They've done everything humanly possible to do it. They've attacked the reinsurance capability. They've attacked the ability for us to market it and let people know what their options are. They've obviously attempted to say they're going to repeal the whole thing. And while that's going on, we need to be on the balls of our feet, actually moving in the other direction to continue expansion, because the people really are with us in this regard. So it's important to be able to be willing to go first in that regard. But we have not seen any structural reasons why this will not work. And the demand from the community continues to accelerate. As I've indicated, we got down to just below 5% uninsured. It's creeped up to 6.2 for a variety of reasons, in part because of the fear instilled by the current administration in D.C. in the public that this won't be here for a long time. And so we thought it was really important for the state to provide security. Now, I do want to allude before I forget, this is not the only thing we're doing in the healthcare field. We think there's multiple adjacent things we need to do. So we've also adopted the nation's first long-term care program, which provides the ability for people to age at home in dignity with 6 months ability minimum to take care of you as you age. This is obviously a tidal wave of folks who are going to be in that situation. Mm-hmm. We think that's an important adjunct to this. Mm-hmm. We are reforming our mental health system to integrate physical and mental health, because when you talk about reducing costs, the integration of physical and mental health can really help, because it's just crazy to have two separate systems right now treating one person, and we know the connection between mental and physical health. We are moving aggressively in the opiate crisis in a variety of ways, and we're building health-related issues into our transportation planning and into our systems of providing health care for our state employees, which now have incentives for healthy living, right? Mm-hmm. And that's helping people live healthier. So I just point this out, that the public option is just one of the many things we got to do.
And on the challenges that you identified, the scope, how big a change of public option is, depends a lot on the breadth of provider participation, also what you pay providers, because that drives cost reduction and how affordable it is. Mm-hmm. And you've been doing some interesting things to confront those challenges, to, how should I put it, convince or leverage providers to participate in the plan. What about the challenges you've been facing today?
Yeah, I think so everything that I talked about, alliance model and out-of-network and reinsurance, those are done legislatively. The public option, we passed the first phase of it last year, but the biggest challenge is we still need to pass the final version to get it done. And the biggest challenge there is, again, the role of the special interest opposed to it, meaning the money, meaning they're literally running hundreds of thousands of dollars of advertisements against the public option on Colorado TV right now from the profits that are made from overcharging patients from big mega hospitals. So we have to plow through that to actually get it done. But that's actually literally occurring: mailings, TV ads, and intense lobbying. So that would be the biggest challenge.
I was going to really ask you how you dealt with the challenge of setting that payment rate for hospitals, which is such a sensitive issue in this, but you just addressed it. So, I think we know your views on
well, again, what we have there, and the bill will be introduced, and there's great legislative champions, Senator Kerry Donovan, Representative Dylan Roberts, both from Western Colorado, which has some of the highest rates in our state, and in many markets in their districts, there's only one insurer. So really, rural legislators who feel strongly about this. But yes, a lot of work went into engaging with the hospitals, with the providers. It's already been endorsed by the community health clinic side, and of course working to, as different hospitals, rural hospitals, critical access care, see how they do under this formula. I think there'll be more enthusiasm from different
corners. It's another
corners.
way in which what the two of you are doing is a really critical thing for everyone to watch, because you're actually now dealing with this challenge of what percent of Medicare rates, how does that work, can we make that work? That hasn't been discussed much in the national discussion of Medicare for all. That's all about losing private insurance.
And let me give you one other thing. We also want to encourage innovation through the public option. So what that means is, while there is a baseline multiple of Medicare rates, that's just a backstop. We would be happy, and the public option can negotiate with any provider for a value-based payment system that, as long as it meets those saving metrics. So they don't have to use those procedural codes. They don't have to do it, based on the rate for each thing. If they can come in at or below that price point for total compensation, basically there's a more nimble waiver process, right? With CMS, good luck, never gonna happen. This is a nimble process where if they can meet that cost metric, we're totally open and encouraging of innovation to do it.
We've also put in a minimum of 135% rate for primary care physicians, because this is we've undercompensated a lot of folks, and we need primary care docs, particularly for deal with healthy living issues. So that's another little provision we put in our system.
Yeah, when I was in state government, we were paying primary care docs $7 for a basic office visit. So yes. Okay, Mike Wallace wants to ask a couple of different questions about some different things. One of them is, and you may have been discussing this at the NGA meetings, there's been a lot of attention lately to the new administration initiative, the Waiverbased block grant initiative. And I wonder if either of you have any views on that, whether you think it will fly, whether you could ever see yourselves taking advantage of it in a form that worked for you, or you have no comment on it at all?
I mean, there is a working presumption in the scientific community that if the president has proposed it, it's not based on any reality, truth, or logic. So we start with that presumption. It can be rebutted with significant evidence. Today, for instance, we had Governor of Kansas on our panel, and I congratulated her for having acquired Kansas City for her state, for instance. And so we have to start with that presumption. I actually have not had a chance to really look at this in any detail, but in general, I think Jared would agree with me that when block grants have come from the Republican Party, they have just been disguised way to deny people services who are most in need in the United States. And that has been repeated through multiple agencies and multiple decades. And so I'd have to be very convinced.
This is a voluntary one states can choose to do.
Right. So yeah, we're evaluating it. Again, I think obviously we certainly like to have discretion at the state level, but the devil's always in the details about what those guardrails are. Is it really state flexibility? Is it something that allows us to move forward? I would again look at kind of the way we approach the public option at the state is we are going to have a more nimble process around innovative payment methods that control costs than anyone will out of Washington. So, I mean, if there's a real opportunity with the Republican or Democratic administration to kind of move some of that flexibility to the state level, we're certainly very excited about that, but we're not there yet on this.
If the goal is flexibility, that's great. What I'm saying is the goal has almost always been reduction of benefits ultimately and reduction of federal expenses ultimately so that they could finance giant tax cuts.
You talk
for
about
the top
flexibility,
1%.
but it's usually about the money.
That's been the motivation behind the block grants to date. So I think you'll find governors always wanting flexibility and adequate financing from the federal government, and that has not been the case.
Now, we've all seen you speak to this one on television a little bit, but do you have just thoughts about how health is playing on the campaign trail right now as an issue, how important it is, how it might morph or change in focus as we get to the general election? I know you've both thought a lot about this, and whoever wants to go first.
You know, Jay's probably thought a lot about it more than me, so I'll let him talk, you know. Go ahead.
Well, all I can say is this will be a principal issue during the general election. The Democratic nominee will be on the right side of the angels and health of the American people, and the opponent will be revealed to be a person who really doesn't care ultimately about the health of folks other than the top 1%. He is looking for a way to reduce Americans' access to health care and continuing to finance his pals in the top 1% with further tax cuts. He's already done that in essence. When he's not blowing up the deficit, he's trying to remove health care from people. Now, this has been, because we haven't had a general presidential debate, this has been kind of subdued in the discussion. But you got to realize, he wants to take health insurance from 800,000 people in my state. Now, I don't think that's going to play well in the general election when his name's on the ballot in Washington State and many other places. And to date, that hasn't really been, it hasn't been in the public consciousness, but that's literally what they're trying to do. Frankly, sometimes you'd almost want to let the Republicans catch the car and see what they do with it, because they would be excommunicated from further public life if they actually accomplish this. So I think it is going to, from an electoral standpoint, is going to be extremely positive for the Democratic candidate, almost whoever it is, on whatever flavor that they are proposing. And I think in the last election cycle, where since the election of Donald Trump, the Democrats have won 645 seats across America, including how many in the House? Was it 40?
Yeah.
41 or something?
I think, yeah.
Including 41. And if you talk to the candidates, that was a major reason for their wins in 2018, which were significant. So I think this is a really good reason to elect a Democratic president, and I know that there's a variety of opinions about which kind of plan, but all of them have a central promise to the American people that we're going to go forward on health care, we're going to retain the coverage you have, and we're going to look for creative ways to reduce costs. None of those are being offered by the Republican Party. And this is one of the things about the debate, or about the current status of the debate. You just can't beat something with nothing. And frankly, that's what the Republican Party is offering right here, except to take away what people have today. So I think we're going to be just fine on this score.
Governor Polis, yeah.
I think the way that we always talk about it, and I ran on it, it's certainly one of the top issues. We want to save you money on healthcare. We want good ideas from the left, the right, the middle. We want your ideas to save people money, and whether it's working with the Trump administration on reimportation of prescription drugs from Canada, whether it's our successful reinsurance waiver that we got from CMS with the support of our entire delegation, Republican and Democratic. We just see it as we need to do something. This is a crisis. America as a country, Colorado as a state, spends twice as much as a percentage of our GDP on healthcare as any other industrialized nation. We're in the middle of the pack on results, whether it's prescription drugs, whether it's out of pocket on deductibles. People are fed up and they want solutions. And I would agree with Jay that Democrats at this time are offering a lot more solutions. We would love to hear some ideas from the other side as well.
Okay. We have some time, and I want to open it up for questions, so you're not just listening to me. We have mics that will go around. Please tell us and the governors who you are, where you're from, and say something good about the governors. Mm-hmm. Who's got the first question? Where are the mics going on? I don't see them.
Here they come.
Okay.
Hi, Jennifer Mizrahi from the Respectability Report. I wanted to ask you about social determinants of health, which are so important, particularly around people with disabilities. Each of you in your states has an increase in the number of people with disabilities that are employed in a year when many of the states are down. And so I wondered if you can address social determinants of health for people with disabilities in your states around employment.
Well, we have made this a high priority of our administration to engage the talents of people with these challenges, and we've been considerably successful. And it's been to the benefit of the whole state of Washington to get the talents of these folks, not just for their benefit, but for the benefit of the whole state of Washington. And it's come from looking for talent and for being willing to make minor accommodations to find the way to use their genius. Tonight, our Lieutenant Governor, who's blind, is getting an award from the Kennedy's Profile and Courage group, and he has inspired many people to come into our state government. I love to see what he's done. By the way, he just climbed Mount Kilimanjaro, which is pretty impressive. And it's come from a very intentional effort, and it doesn't take that much to look at people's opportunities. The technological capability we now have to give people the ability to be fully functioning is amazing. And all you have to do is just look for it a little bit. So we think governors, this is one place where governors can make a difference because we hire 55,000 people. And we have tried to inspire private employers to be equally dedicated to this. And we've had a little success in this regard. But we're not done. The unemployment rate in people who are visually impaired is still way, way too high, with a lot of talent out there. So we're trying to improve our educational opportunity for young people in this regard too.
So I just heard that, statistic that you cited for Colorado. I just heard it's a recent one. I think I heard it a few days ago. So we're very excited about increased workforce participation from adults with disabilities. Part of that is our tight labor market. I think that's probably also the case in Washington. We have record low unemployment, a strong economy, and of course we welcome expansions of the workforce, right? And that's one of the reasons we focus on early childhood education, additional kindergarten, preschool. We went to full day kindergarten that allows a second parent to return to work sooner. It means incorporating people who are disabled into the workforce. It means our dreamer population. So a lot of that work is around how we can better grow as a state with all of us together, a Colorado for all.
Next question.
I'm Sarah Hansard with Bloomberg Law. Could you all address the issue that keeps coming up, especially from hospitals, that Medicare doesn't pay enough? That's why they have to charge employers so much more. And I believe that there's like a CBO study, you may know this, CBO and a CMS actuary study, that are saying, well, if you just paid Medicare rates, all these hospitals would be underwater. what is going on there in your view, and what do you think of that?
Yeah, I mean, I don't think anybody disputes that. In fact, we have analytics behind it. In our state, the break-even point for hospitals, this is on average, but the average break-even point is 135% of Medicare. So yes, if Medicare was the payer, they would reconfigure, there'd be less of them or whatever it was. Now, beyond that 135, you do have to drill down, right? There are some that are break even at Medicare. There are some that are inefficient that might be at 160% of Medicare. I mean, there's going to be a range about the cost basis expressed as a reimbursement multiple of Medicare. But is it true? Absolutely, that for most providers, Medicare reimbursement is a loss leader. That is a generally, not universally, but generally that is a true statement.
I mean, that's why we're at 160. So
Yep.
This is, we believe, a sustainable model. And I would point out, though, is having people who are not insured ultimately is more expensive to hospitals because they show up in the emergency department when they could have been treated preventatively to reduce total costs, and then it becomes totally uncompensated care for the hospital. So we think these are going to help the stability of our hospitals, particularly rural hospitals. We had special provisions for rural hospitals because of their financial challenges in our plan. We think it's right on the money. By the way, I want to mention something when the question was asked about disabilities. There's another thing we've done in Washington I think it's important, which is to have a really well-financed family medical leave policy. And we now have the first application of that. We're getting thousands of applications. This helps people when they are ill get better, right? So they can actually get better when they're sick. They got a broken leg, you can stay home a little bit longer to get well because it's financed. And we're proud of this because it's the best financed program in the country, and I consider it part of the healthcare system.
Okay,
By the way, we're working on paid family leave in Colorado as well, so we hope to have that as an accomplishment soon.
I have an advantage. I started earlier than Jared. So.
Who's got the next question?
Hi, I'm Leslie Small with Health Plan Weekly. I'm curious what it's been like working with insurers with this, because I know that you guys are sort of using them as contractors in this sense, and nationally insurers aren't big fans of the public option. They're sort of equating it with Medicare for all, so curious about that dynamic.
Well, I think there's an opening here for, and again, insurers by and large probably don't necessarily love our concept. I don't know if they love Jay's either. But again, here's the thing. You know, folks here, look, is there a world where you're going to be cut out, or is there a world where you find a way to be part of the solution? So this is a way where you can be part of the solution and make it work. And again, there's a very pragmatic discussion. I think there's a desire in some quarters to understand they want to be part of this. The alternative is not the status quo. The alternative is a system that really goes around and no longer has that as part of the system.
How do you see your plans evolving in terms of who participates, starting with a focus on the non-group market, but where do you see it ultimately potentially going? Small employers, even larger employers?
Yeah, so ours is individual market first, 7%. Yeah. Then the next stage would be the small group market, which is similar sized. And again, because of the transparency in the pricing models, we also help, and obviously, again, hospitals might not love this, but this can save people money. We hope that, again, the transparency around this pricing, the analytics, provides additional negotiating leverage for the large group plans, too, who can see what's being done through the public option.
And I just want to point out, when Jared talked about maybe this is only 15% of the market, you think, oh, it's only a small amount.
Yeah, it's a lot.
But it's 100% of the people who don't have coverage.
Yep.
So this is a big deal in people's individual lives, even though it sounds like a small percentage.
And it's bigger than it sounds for another reason, because the federal payers, Medicare and Medicaid, are so big. So that's a big chunk. So on the private side, this is actually a much bigger piece than just 15%. Because I mean, you take Medicare and Medicaid off, and then you're looking at what's left, and then we're trying to figure that out in our states.
Governor Inslee, you said you went with a design which administers your plan through private insurers, largely for administrative reasons. Were your reasons similar, or was it politics, or you didn't want a Medicaid waiver if you built it on Medicaid, or what was it?
Yeah, I mean, I think it's just we have no desire to run a state insurance company. Yeah. I mean, we want to be the regulators. Mm-hmm. We are the regulators. Mm-hmm. It's hard to be a regulator and a regulatee, I guess. Mm-hmm. You know, it's just hard to see what that would look like. So we are thrilled to do this through those channel partners.
Okay, the question was asked, you know, how we get along with the insurance companies. And I think they look at me the same way my wife looks at me, which is that much less than ideal, but she's stuck with me. So we need to work together.
Wow.
Actually, we get along pretty well. After 47 years.
We have time for a couple more. I'm not in charge. Here we go, wherever the mics are. Yeah.
Hi. Just wanted to ask about how you're going to ensure high quality of healthcare through this public health option. I know Medicare has a quality payment program. Wonder if there are any metrics that you're tracking to as your bar.
Well, I mean, look, it would have the same quality as the overall marketplace. I mean, I'd agree we need to move quality forward in kind of how we look at healthcare. But this is a payer. It's simply a payer. It's just a different configuration on the current payers. And it has these elements that transfer cost savings to the person paying the premiums rather than being absorbed by others across the way. So again, you know, there's always going to be a competition on both cost and quality. This in no way detracts from quality, right? I mean, these programs are going to be designed with the same networks as others, and there's going to be some that are narrower and some that are wider, but I mean, there's not a issue there. It's the same providers. But we also want to reduce costs and continue to increase accountability.
There is a capacity to judge quality in new ways, though, which is, you know, is your blood pressure under control? Is your weight right? Are you exercising a little bit? So we define those as value in itself. So there's new ways to define quality. And again, this is one of the reasons why we've built in an incentive for primary care physicians who can deal with well-being, which is at the heart of 35% of our morbidity. So we think this gives us a new tool.
Yeah, we have a hard cutoff. We'll take one more, and then I'll see if you have final comments you'd like to make.
Governor Inslee, during your presidential campaign, you focused primarily on the environment and climate change. I would be interested in hearing both of your thoughts on the link between insurance coverage and the environment and changes to the climate.
Well, don't get me started, right? So what I would say is, in general, the link between climate change and health is vastly understood. And because this is a health issue, climate change is fundamentally a health issue. And when we attack carbon pollution, it's probably one of the single largest thing we can do to improve people's health. Because cardiovascular disease, cancer, asthma, all a major contributor is fossil fuel pollution. And every time we take a step to reduce carbon pollution, it by necessity improves asthma rates and cardiovascular disease rates and cancer rates. And the numbers are astronomical. I first kind of tumbled to this. I met a 14-year-old Latina she lives in the industrial area in Seattle a few years ago, and she said she was 11 before she realized that some kids didn't have asthma because everybody else had asthma because they're living next to the freeway and in an industrial area. So she went out and did her own research to look at the rates of asthma depending where you lived. And every quarter mile closer you live to the freeway, asthma rates go up just really dramatically. Subsequently, this was confirmed by epidemiologists at the University of Washington. So when we attack climate change, we are doing some of the best possible things we can do for our health, particularly for our children. Now, as the climate worsens, there are secondary effects due to forest fires. And forest fires are now not only burning our forests, and we've lost 4 in the last 2 years in my state fighting these forest fires, but the smoke for the fires also becomes a respiratory issue. For the first time in my life, I've always lived in the Seattle area, there were ash on the hood of people's cars when they woke up last summer. Never happened before during my lifetime. The Speaker of our House, during her address, told us that her brother is now fighting fires in Australia. He's from Washington State. He works for the Bureau of Land Management. And I remember when just a couple weeks ago, I heard that 3 firefighters from the Northwest had died fighting fires in Australia. And the first thing that went through my mind was, geez, I hope it wasn't Lori Jenkins' brother. And then I later realized, well, it wasn't, but I should be equally sad that somebody else's brother. We're all connected here. This is a health issue as much as an environmental issue.
Great question, Governor Polis. Do you want?
Yeah, I would also just from a very more direct perspective, just bring it to air quality issues. So we have a real smog problem in our Denver metropolitan area. and the direct, very tangible, measurable impact of that, asthma rates, respiratory issues, especially the very young and the very old, is very tangible. So it's something that you can really put a price on, not obviously the human suffering piece, but the healthcare piece, and you can figure out what the dollar cost of that is. So we're taking a lot of action, whether it's implementing electric vehicle standards, looking at multimodal transportation opportunities, increasing broadband and opportunities for telecommuting, kind of using all of these different approaches to reduce the vehicles' miles traveled and reduce our smog.
Okay, any final comments or messages for the national health community from either of you before our time is up?
But my message is, if you're thinking about a vacation this summer, realize that Washington is Colorado with a seashore. Okay, so just hope you think about that.
And we'll just say that Colorado is Washington with real mountains. They might have one mountain. We have like I don't know, 150. Look, I mean, saving people money on healthcare front and center. Americans are smart. People get it. We're being ripped off. We're being ripped off every way from Sunday, and they just want a solution. People are sick and tired of the special interests, for their own profit to prevent systemic change. And whatever that form takes, people want ideas that are simply going to get them a better deal, like most of the other Western industrialized countries already have today.
Okay, well, on behalf of everyone in healthcare and whatever your views on stuff, thank you both for being leaders on our issue.
Thank you.
Thank you.
Thank you. You're the new Mike Wallace. Henry Wallace, forever.
I actually knew the old one.
Yeah.
Thank you.
Thank you so much.
Jay, good to see you, buddy.